This is the normal colon. The colon is also called the large intestine. So, this one, the verticula disease consists of three conditions that involves the development of small sac or pockets in the wall of colon. So, yan. So, mayroong mga butas-butas. So, bleeding, diverticulosis. Okay. So, diverticulosis, formation of tiny pockets or diverticula. So, yan. Ang dami pala na niya. Polyps. So, isa to yung colon polyps. So, small clumps of cells that form on the lining of the colon. Most colon polyps are harmless, but over time, some colon polyps can develop into colon cancer, which is often fatal when found in its later stages. So, siguro yun na yung pagka yung colon cancer na. Ito, rectal cancer tumor. Both colon and rectal cancer affects the large intestine, which is the lowest part of the digestive system, but they start in different places within it. So, yan, may mga okay, and this one is hemorrhoid, also called piles, are swollen veins in your anus and lower rectum, similar to varicose veins. Hemorrhoids has number of causes, although often causes unknown. So now we know.
Heavenly Father, thank you for this day. We thank you for being able to see, hear, touch, feel, and walk this morning. Provide a way for those who lack any of these, we pray. Lord, we are blessed because you are a forgiving God and an understanding God. You've done so much for us and still keep on blessing us, as well as our families and friends. We say thank you. Thank you for opening doors to bless and close doors that would be detrimental. Forgive us our sins, known and unknown. Continue to keep us safe from all dangers and harm, seen and unseen. Let us start today with a new attitude and plenty of gratitude. In Jesus' name, amen. Amen. In the name of Father, the Son, and the Spirit.
Our administration of the medical city, led by Dr. Eugene Ramos, and the different departments who are actively involved in this activity. We would like to welcome our patients, our allied medical personnel, and welcome to this symposium, which is titled Advances in the Screening and Management of Colorectal Cancer. This is in celebration of Colorectal Cancer Awareness Month, which is done every year during the month of March. I am Dr. Jude Luis. I'm a gastroenterologist from the Colorectal Clinic of the Medical City and a strong advocate for colorectal cancer screening. This activity is actually sponsored by the Colorectal Clinic, the Cancer Center, and the Center for Patient Partnership. Colorectal cancer is the third most common cancer in the world. It is now the third most common cancer in the Philippines as well. Globally, around 1,400,000 persons are diagnosed with colorectal cancer every year. And around half of them die from that disease at the time of at the year of the diagnosis. To give our opening remarks, we have a very accomplished surgeon. He took up his medical school at the University of Santo Tomas. He took up his residency in otorhinolaryngology at the University of Santo Tomas as well. He had further training, his fellowship in two institutions in Japan, Osaka University and the National Cancer Center in Tokyo. Currently, he is the director of the Cancer Center and is one of the proponents of the multidisciplinary approach in the management of cancer. Let us welcome Dr. Daniel Alonzo.
Thank you, Jude, for the kind introduction. I'd like to start by asking a question. How can Medical City contribute to cancer care in the country? We have done quite a lot. We have been working hard to offer comprehensive cancer care across many cancer sites, consistently aiming to achieve the highest level of outcomes in terms of survival and quality of life. We offer our patients all possible treatment options, and it is our goal to make the goal to choose the most modern and most effective treatment for our patients. And we'd like to do this across all stages of the disease and across all cancer sites. At present, we are positioning ourselves to offer these services to a wider geographical area. It is a fact that outcomes of treatment are much better when the disease is diagnosed early. So we're exerting more effort in the screening and early diagnosis of cancer. The Medical City can contribute to early diagnosis by making screening available and accessible, not only in the main hospital, but also in our network hospitals and clinics. And of course, this starts with detection, screening, and early diagnosis. I'd like to congratulate the group of Dr. June Ruiz, Dr. Rami Rojas, and Dr. Jeff Tolentino for being unrelenting in their efforts to move this program forward. And I strongly urge you to include our network hospitals and clinics. And this is not going to be very difficult because Dr. Rojas is so passionate about building the TMC Cancer Network. Our gratitude to Assistant Secretary Eric Tayag for gracing the occasion, Dr. Cairo, Dr. Eugene Ramos, thank you. And I welcome you all to this activity and expect many more to come in the future. Thank you.
Medical City and the cancer sector in the years to come. Let us start first with the house rules and reminders. Please turn off your cell phone or put them in silent mode. Due to limited time, there will be nothing declared as the Colorectal Cancer Awareness Month since 1999. And this actually started in America by the CDC. And this was started as a movement to fight against colorectal cancer. Just to size up the success over there, in year 2002, only 50% of Americans were screened for colorectal cancer. But because of this campaign, after 10 years, in 2012, 65% of the Americans had been screened in 2002. The doctors here at the Medical City, the gastroenterologists, the colorectal surgeons, the oncologists, have been among the first to promote this advocacy in this country. Among Filipinos, colorectal cancer used to be number 4 after liver cancer just a few years ago. Now it is number 3. So you could see that there is a concern for doctors and patients about the rise in colorectal cancer. Mind you, just for information, the most common cancers in the Philippines are breast cancer and then lung cancer. I know it will be an uphill battle to fight against colorectal cancer, but I think we could reverse the upward trend by uniting and pushing for screening for this cancer. As you know, screening can save lives. screening can reduce your risk for colorectal cancer up to 70%. The earlier the cancer is diagnosed, the better the survival and the potential for cure is easily achieved. Remember the saying, the ounce of prevention is worth the pound of cure. So this is very true for colorectal cancer. You will be listening to our distinguished speakers, and at the end of the symposium, we hope you could take home the message that colorectal cancer is preventable, it is treatable, and beatable. Again, it's preventable, it's treatable, and beatable. Our first topic will be on updates in the diagnosis and screening of colorectal cancer. Our first speaker is someone that we can really be proud of. He is a homegrown talent here at the Medical City. He finished his medical school at the University of Santo Tomas. He took up his residency right here at the Medical City. He did his gastroenterology fellowship at the Cardinal Santos Medical Center, and he is an active consultant of the Medical City, Cardinal Santos, and Quirino Memorial Medical Center. Let us welcome Dr. John Jeffrey Palisok from the Department of Medicine and Section of Gastroenterology.
Dr. Ruiz for the kind introduction. I was tasked to give a discussion on the updates and diagnosis and screening of colorectal cancer. So this is the molecular genetics in colorectal cancer. So from a normal colon, you have the hereditary syndromes, ABCs, you have hyperproliferative epithelium, you have the KRAS mutation, P3 deletion, and you have adenoma. And a further accumulation of genetic abnormalities, you will develop carcinoma. Colorectal carcinogenesis, the adenoma to carcinoma sequence, 66 to 90% of which are sporadic cases of colorectal cancer. The polyp dwell time, usually around 15 to 20 years. Non-adenomatous pathway, which compose around 10 to 30% of the colorectal cancers, involve the flat adenomas, the preadenomas, the hyperplastic, and serrated adenomas. So the basics of colorectal cancer, it affects men and women of all races. Most colon cancers arise in pre-existing colonic polyps. It has a long, often asymptomatic natural history, emerges from a progression of several mutations in gene controlling cell growth and DNA repair. Identification and early endoscopic removal of precursor lesions like your polyps will prevent colon cancer. In the early stages of the disease, patients may still be asymptomatic. The clue for asymptomatic patients, usually the clue of the presence of malignancy may be a positive occult fecal exam. Abdominal pain or presence of a palpable abdominal mass in later stages of the cancer. Obstructive symptoms include constipation, which sometimes alternate with increases in frequency of loose stools. It may also present with lower GI bleeding, the easy fatigability, shortness of breath, and body weakness and angina may be secondary to blood loss, secondary to the tumor bleed. For the colorectal cancer, I'll be discussing the burden of the disease, the risk factors, and the earlier prevention or screening. Basically, I'll be touching on the Asia-Pacific consensus on screening of colorectal cancer. Colorectal cancer is the third most commonly diagnosed cancer in males and females, with an estimated 1.4 million cases and 693,900 deaths occurring in 2012. The highest incidence rates are in Austria, New Zealand, Europe, and Northern America. Rates are low in Africa and South Central Asia. Rates are higher in men than in women in most parts of the world. So this is basically a stat on care of global cancer statistics. Where worldwide, we see that estimated new cases, colorectal cancer ranks around third for male, and for female, second. And the estimated death for males, it's fourth, and for females, it's on the third. The prevalence and incidence of colorectal cancer Increasingly prevalent malignancy in the Philippines. Currently, it's the most common cancer of the GI tract. Colon cancer is the fourth leading cause of cancer-related deaths in the country. Now it's the fourth. The 2010 Philippine Cancer Vaccine estimates by Lodico the incidence of mortality and survival. In 2010, cancers of the colon rectum combined will rank fourth for both sexes, third among males and fourth among females. In 2010, there will be 5,787 new cases in both sexes. The incidence rates begins to rise steeply at age 50 years in both males and females, and grows steadily from 1980 to 2002, with an annual change of 3% to 3.7% in males and females respectively. So this simply tells us, all the data from 1980 to 2002, it simply tells us there's really an increasing incidence of colorectal cancer, most probably because there's also increasing awareness for screening for colorectal cancer. This is the incidence of cancer in the Philippines based on the Global Can 2008, wherein colorectal for men is the fourth leading cause, while for women it's also the fourth leading cause of cancer. The incidence of cancer in the Philippines, like what I said, it's the fourth leading cause of colorectal cancer. Age standardized incidence rates of various cancers, you'll see the increasing rise in colorectal cancer. And the distribution of colorectal cancer according to predisposition, the sporadic cases are 73% of cases. Colorectal cancer incidence in Asia Pacific, it's the fourth most common cancer in Asia. 300 deaths annually, wide variation incidence more in developed regions. Time trend of colorectal cancer incidence in selected Asia Pacific countries. So you see, like I mentioned a while ago, that Australia is one of the increasing incidence of colorectal cancer. Secondary to aging population, change in lifestyle, smoking, obesity are just one of the risk factors. 5 countries from Asia Pacific are among the top 20 highest incidence rates in the world. You have Korea as the number 1. Second to that would be Australia, New Zealand, Singapore, and Japan. And the future burden of colorectal cancer in Asia, as predicted by GlobalCan, by 2035, the incidence will reach 1,150,000. This is a cancer registry here in Medical City. As you can see, from 2011 to 2016, the percentage increase in the cases of colorectal cancer has increased. Risk factors, you have smoking, which is dose dependent, alcohol, red meat, processed meat, diabetes, and obesity. Recently, the WHO released it was also published locally in our newspapers, where they said that red meat, thoroughly reviewing the accumulated scientific literature, a working group of 22 experts from 10 countries convened, and it showed that consumption of red meat is probably carcinogenic to humans based on limited evidence that the consumption of red meat causes cancer in humans and strong mechanistic evidence supporting a carcinogenic effect. Also, a processed meat, which was classified as carcinogenic in human, group 1, based on sufficient evidence in humans in that consumption of processed meat causes colorectal cancer. Other risk factors are the personal and family history of colorectal cancer and the presence of polyps. Genetic syndromes like your familiar adenomatous polyposis, inflammatory bowel disease, most commonly ulcerative colitis. So with what I have just shown, there's definitely a strong case for screening, either by looking at blood in the stool, or by doing your flexible colonoscopy, flexible sigmoidoscopy, colonoscopy, or CT colonography. The benefits of colorectal screening, by just doing your fecal occult blood test, the mortality reduction is around 25%. By doing flexible sigmoidoscopy, there's a 43% mortality reduction, same with the combination of the two, while for colonoscopy, After initial screening and polypectomy there's a reduction of 76 to 90%. Screening reduces incidence and mortality. This is an example of a graph in the US wherein the decline in the colorectal incidence, the reasons of which are effect of increased screening, reduction of risk factors, and improved treatment. So what are the screening techniques for colorectal cancer? So you have the fecal occult blood test, the fecal immunochemical test, which is done every year, flexible sigmoidoscopy every 5 years, or fecal occult blood test every year plus a flexible sigmoidoscopy every 5 years. Double contrast barium enema every 5 to 10 years, or colonoscopy every 10 years. This is based on the American College of Gastroenterology. So, has any one of you undergone a colonoscopy? So, Dr. Tyler has done colonoscopy. So basically, colonoscopy is a very short procedure, very safe procedure nowadays. It's being done in hospital, in clinics in the malls. So it's the screening and I think the availability of the scopes, which is nowadays very readily available. So it is a diagnostic and therapeutic examination of the entire colon with capability to remove polyps and do biopsies. It is considered the most effective tool for colorectal screening and remains the preferred screening test. The advantage of performing colonoscopy over the sigmoidoscopy is that the latter would not be able to detect proximal lesions. The overall risk of complications around 0.3%. Risk is higher by 2% when you do polypectomy, and the main complication of colonoscopy is perforation and bleeding. In 2008, there's an Asia-Pacific consensus on the screening of colorectal cancer. Screening starts at age 50 based on that consensus. Some countries do not have similar evidence of colorectal cancer in the West. Fecal occult blood test during that time, the guaiac-based, the fecal immunochemical test, the flexible sigmoidoscopy and colonoscopy are recommended as colorectal cancer screening. Barium enema and CT colonography are not recommended as primary screening modalities. The tendency towards proximal migration of colonic polyps were identified. National screening guidelines during that time was not available in some Asian countries. Public education is essential in promoting colorectal cancer, and the rising mortality rates was observed. The recent updated Asia-Pacific Consensus recommendation on colorectal cancer, it was recently done and published in 2015, which included 14 countries, including the Philippines. The significance of the study in comparison to the 2008 consensus of colorectal, the 2008 consensus, which simply mentions the start of colon cancer screening at age 50 and the use of fecal occult blood and flexible sigmoidoscopy colonoscopy, and making fecal occult blood test as the first choice for colorectal screening in resource-limited countries. The new ones in 2015 update, they now included the age range for colorectal screening. Because a lot of patients would ask you, up to when do you screen for colon cancer? For Asia Pacific, they have established that the age of 50 to 75 would be more beneficial to screen as opposed to screening patients from 76 onwards. Because they have found out that there is less benefit on screening them on those ages. The updated Asia-Pacific Consensus also recommends a risk-stratified scoring system recommended to select high-risk patients for early colonoscopy. It basically involves the risk factors of age, sex, family history, and smoking. If you are aged 50 to 69, you are given 2 points. For 70 years old, you are given 3 points. For being male, you have 1 point. Family history, 2 points. And for smoking history, 1 point. And based on this one, you are placed under a risk stratification for low risk, intermediate risk, and high risk. Simply tells us that if you fall under intermediate risk, you have 2.6 risk of developing advanced neoplasia, and if you are high risk, you have 4.3 times the risk of developing advanced neoplasia. The quantitative fecal immunochemical test is now the preferred average risk screening for average risk patient. Fecal whole blood test is not being used because of its false positive results and because of the preparation, dietary preparation you have to undergo prior to the test, as opposed to fecal immunochemical test. This one is readily available here in Medical City. Flexible sigmoidoscopy is effective for colorectal screening, but it's not the first choice since you'll be only screening the left or the distal part of your colon, and you might miss out lesions on the proximal part. Colonoscopy is effective for colorectal screening, and it's a preferred choice for colorectal screening in increased risk individuals. CT colonography is not recommended for colorectal cancer, but it may be used in cases when total colonoscopy is not possible. The recommendation for surveillance and screening intervals. The Asia-Pacific Guide Consensus adopted the U.S. Multi-Society Task Force on Colorectal Cancer Guidelines for colonoscopy surveillance. So if you don't have any polyps on your first colonoscopy, your next screening will be after 10 years. For presence of polyp that is less than 10 millimeter, hyperplastic polyps in the rectum and sigmoid after 10 years. For 1 to 2 small, less than 10 millimeter tubular adenomas, your next surveillance colonoscopy will be after 5 to 10 years. For 3 to 10 tubular adenomas, every 3 years. For more than 10 adenomas, less than 3 years. 1 or more tubular adenomas of more than 10 millimeter, that's every 3 years. For the presence of 1 villus adenoma, you do your surveillance every 3 years. Adenoma with high-grade dysplasia, you do it every 3 years. For serrated lesions, as well. For sessile serrated polyps less than 10 millimeter with no dysplasia, you do it every 5 years. For sessile serrated polyps more than 10 millimeter, for sessile serrated polyps with dysplasia, you do it every 3 years. And for serrated polyposis syndrome, every year. This updated Asia-Pacific consensus, quality control measures should also be included in the CRC screening programs. So these are the quality indicators that is being done and promoted by the Philippine Society of Gastroenterology. For documentation, you need patient demographics, pre-procedure assessment risk, documentation of prior exam interval, documentation of qualitative bowel preparation. In the Philippine Society of Gastroenterologists and most of the training institutions, they make use of the Boston Bowel Preparation Scale scoring, wherein the adequacy of 6/9 bowel preparation more or less tells us you have an adequate bowel preparation, and the least likely that you might miss lesions is less. You also have performance quality indicators, follow-up communication, and key outcomes. Ancillary methods with exception to chromoendoscopy have not proven to be superior to high-definition white light endoscopy in identifying adenoma. Chromoendoscopy is basically making use of indigo carmine to highlight flat polyps in identifying pathological lesions. Endoscopic imaging modalities and efficacy in CRC screening based on the study, high-definition white light probably effective in adenoma detection rate, but chromoendoscopy definitely effective in improving adenoma detection rate. The use of NDI or your FICE or your eye stent, there had not been really, based on the study, has not shown any improvement in adenoma detection rate. These are basically the narrowband imaging. For my last slide, I would like to impart to you a small message. It's actually an info commercial tasked by the Society of Gastroenterology, Philippine Society of Gastroenterology, with a local pharmaceutical company.
Dear Mommy, sana kinukulit mo pa rin akong magpatugtog ng Christmas songs kahit Mayo pa lang. Sana kinukulit mo pa rin akong gumising ng maaga para mag-ballroom. Sana kinukulit mo pa rin akong i-text ng mga amiga mo para mag-matchong. Sana kinukulit mo pa rin akong mag-midnight snack. Sana pinulit kitang magpa-check up ng mas maaga para hindi umabot sa stage 4 ang colon cancer. Siguro hanggang ngayon, nagkukulitan pa din tayo. Don't worry na, magpapascreen ako para sa ako mo.
Actually, that video was actually scheduled to be shown later in this program, so I didn't realize that it will be shown by Dr. Paliso. But we would like to thank Westmont and the local Philippine Society of Gastroenterology for coming up with that screening video. I want to stress additional points on from the lecture of Dr. Jeffrey Paliso that colorectal cancer, we basically have modifiable factors and non-modifiable factors. So the non-modifiable factor that is really important that we're trying to push is age. You cannot really do anything with age. So when you reach 50 years old, we would recommend screening for colorectal cancer. And 50 is not just a number that came out of nowhere. 90% of patients with colorectal cancer are 50 and above. So there is a reason why there is a designated age for screening. The non-modifiable factors would be the healthy lifestyle that Dr. Paliso has mentioned. Exercise, eating a healthy diet, avoidance of alcohol. Those are factors that you could actually modify. So that's why they are called modifiable factors as risk factors for colorectal cancer. This month marked the anniversary of the Colorectal Clinic. It's celebrating its fourth year anniversary this month. The Colorectal Clinic is the first hospital-based specialty clinic that caters to patients with colorectal and anorectal problems, including colorectal cancer. The Colorectal Clinic was inaugurated in March 2013, so it has been 4 years. The major advocacy of the clinic was the fight against colorectal cancer, and the clinic aims to be at the forefront of the battle of the Filipinos against colorectal cancer. Even before the clinic opened, some of the doctors have already been advocating screening and early diagnosis. This was taken in 2010. We see Dr. Manuel Rojas spearheading the colorectal cancer program. Every year, the doctors advocate this important message to our patients that they need to be screened. We have conducted lay forums. This was in 2015. We went out to the communities in Pasig City to talk about screening. We also had our lay forum in 2016. And last year, we had a major project in which we had a multidisciplinary symposium on the management and treatment of colorectal cancer, which was a doctor symposium. The clinic was also the prime mover in the cancer screening lecture series that was done with the Cancer Center that we catered to our satellite clinic physicians. The clinic also led other movements in surgical care, like enhanced recovery after surgery program, or the ERICS, which has resulted in lesser complications and shorter hospital stay. The doctors of the clinic have also been active in promoting education to the general public. Our next speaker will be talking about the recent technical advances in colorectal surgery. His name is synonymous with colorectal clinic. I remember when I left Kaiser Permanente in California in 2013, which, by the way, has the best screening programs in America, in which they actually have 80% of their patients are actually screened for colorectal cancer. I Googled colon cancer screening advocacy Philippines, and while doing the search, it's the name of our speaker that usually appears in the search. So let me introduce him. He is a medical school graduate of the De La Salle University Health Sciences. He took up his colorectal surgery residency at the Philippine General Hospital. He had additional training in anorectal physiology and endorectal ultrasonography at the University of Minnesota. He is the current chairman of the Department of Surgery, the consultant director of the Colorectal Clinic, a regent of the Philippine College of Surgeons, and a past president of the Philippine Society of Colorectal Surgeons. Ladies and gentlemen, let us welcome Dr. Manuel Francisco Rojas.
Thank you, June. Undersecretary Payag, Vice President Eugene Ramos, and the head of the cancer program, Dan Alonso. I'd like to thank you all for allowing us to celebrate again Colorectal Cancer Awareness Month. I'd like to welcome also our guests, both doctors and patients. I think Dr. Palisok has explained to you how common colorectal cancer is. And it's never going to go away because we all want the Philippines to progress and become industrialized. If you look at the other countries, when they become more progressive, when they become richer, when they live longer, the incidence of colorectal cancer goes up. And the common denominator is living longer. The longer you live, your risk goes up. So we know it's going to be a very common problem still in the next decades. And it's also one of the most curable and one of the most preventable cancers. It probably is the most curable and preventable because there's evidence that shows screening works. If you pick it up early, it's also very curable. And the mainstay of cure is usually surgery. If you can remove it early, you don't need chemotherapy, you don't need radiotherapy, as long as it's early. So surgery is the mainstay of treatment, and I won't go into the basic surgery. I'm here to talk to you about what's new in surgery and what our colorectal cancer program, because that's our advocacy. How do we treat colorectal cancer better for the Philippines? And it's not just me as an individual doctor or my anesthesiologist or my oncologist. We have to develop programs, systems. We need to develop a screening program. We need to develop a surgical program. And I'll talk about some of that today. So let me talk about first, this is the colorectal clinic I think we showed. It's the first one we've had in the country. We'd like to thank upper management for allowing us to build a colorectal clinic. As you cannot have a cancer program without a team of doctors and a program in place. You can't just have people holding clinic in their own little space and doing it individually. If you go downstairs now, and the culminating activity of many years of trying to move the screening program, there's a little balloon of the colon. You'll see it by the fountain. You can walk right into it and you can understand what a polyp is, what the cancer looks like. There's a little hemorrhoid pa. So that balloon we will use to bring all over the country to spread awareness for colorectal cancer. Anyway, I'm here to talk to you about three recent innovations we've done in our colorectal cancer program in Medical City. The first one is robotic surgery. The second one is HIPEC, as we call it, hyperthermic intraperitoneal chemotherapy. And the third one is our enhanced recovery after surgery program. Let me start off with the robotics. No? The world of surgery is becoming more and more, or less and less invasive. Instead of the big surgeries we did in the past, we now can do for early tumors small little incisions so you don't have big wounds. But sometimes these operations are not easy because it's like operating with a chopstick. The surgeon is like holding a chopstick. And the innovation now is, instead of like holding a chopstick, we have the robot that moves better than the human hand in a very tight space. And this is the growth of the robotic procedures and the data they have over the years worldwide. And the advantage is, of course, instead of having the big wounds we used to do before, we now have little small wounds. And either laparoscopy or the robot allows us to do that. However, the robot has 3D vision. The surgeon completely controls it. It's not the robot that moves on its own. We control it. It's very stable. It zooms in. If my hand can only move this way, the robot's arms can move around. So it's got a lot of dexterity. Okay? And it's very safe. The moment we remove our eyes and our head from the robot will stop. It will not move without the surgeon moving. This is the robot attached to the patient. The surgeon is actually a few meters on the side with his hands on the robotic arms and moving the robot. So this is how it looks. The robot is on the patient. The surgeon is actually on the side controlling the robot. The advantage is more precision in smaller movements. Its articulation is beyond what the human hand can do in many ways. Certainly not with the laparoscopic instrument. It's 3D. It's easier for the surgeon. Kung medyo matanda na yung kamay ng surgeon at nanginginig na, hindi yan na sa robot. Hindi rin nanginginig yung robot. It's stable, no? And that's why the robot is very effective, is because there are some areas of the body that are very tight. Ang hirap operahan. And for instance, in the prostate, that's the most common indication for robotic surgery, prostate. Kailangan mo idugtong yung daanan ng ihi, yung urethra. And you cannot stitch that with the laparoscope. It's so hard. With the robot, that makes it easy. Okay. There is some evidence for colon surgery, precise removal of cancer tissue, low blood loss, low rate of complications, faster return to recovery, short hospital stay. But for us in colorectal surgery, we find the robot most useful for rectal cancer. And I'll just show you this slide showing the survival in the Philippines in 2005. And it doesn't change much. Colon cancer, the survival is around 47%. However, if it's rectum, and this is 5-year survival, it's only just below 20%. So there is worse survival with rectal cancer. And the problem with that is because the rectum is inside the pelvis. It's a very tight space. It's harder to operate. And this guy, Dr. Bill Hill, we invited him over to lecture to us surgeons before. He's one of the main leaders in rectal cancer surgery who showed that you can improve the survival of rectal cancer with better surgery. So here he is saying in no other countries have such variations in outcomes in rectal cancer been observed. There is no area of cancer treatment where the development of a better surgical technique has much to offer the patient. At dapat maganda yung pagkatanggal. Importante. Kung wak-wak ang tinatanggal namin, hindi maganda sa outcomes ng cancer. So it has to be very precise. And the problem when we do this laparoscopically, although maliit ang sugat, is the instruments don't bend. They're very straight instruments. And yet we have to work in this area. We have to work in this area down here where the instruments have a hard time getting into. So look at the straight instruments, they don't bend in, and yet that area is very tight and narrow. So I'm just going to show you a little video of the one on the left is laparoscopy, no? If you notice, okay, I can do it, it's easy, I've been doing it a vast, but look at how unstable it is. The robot is on the right, and we're doing the same thing, but if you notice, the robot is not moving, the camera is not moving. Here in laparoscopy, my cameraman is the one holding it, and if he's tired already, it's not as stable, somebody else has to assist for me. Well, in the robot is also you doing the assistance. So if you look at the movement, it's a little more stable. That's the advantage I find with the robot. Okay. We also have a training program already downstairs because we're the first one who got the robot in the country. We also have another robot. We just bought a new one. So the old one we're using for training. And so this is what the robot can do. Look at how it can tie, it can stitch. So we train our surgeons now on robotics. Okay, so that's our robotic program. And that's what we can do for colorectal surgery now. The most important objective of rectal cancer surgery is a good specimen. Minimally invasive procedure is better than open because it's faster recovery. Robotic surgery makes minimally invasive surgery easier for the surgeon and the patient. But of course, training is required. Now, okay, let me go on to the other spectrum. The other spectrum is many times we do not get colorectal cancers early, and so many of these patients will progress to stage 4. Now, stage 4 can be in the liver, in the lungs, or all over. And we have a program where if it's in the liver, we have a liver cancer program where we can take out this spread in the liver with improvements in survival for stage 4. We also have one for thoracic. Our newest addition, although it's not really new, we've had it for a couple of years already, is what we call HIPEC, hyperthermic intraperitoneal chemotherapy. When the tumors have spread into the tummy, all over, and before we couldn't do anything, and chemotherapy could not do anything also for it that much, no? It carried a worse prognosis and other signs of metastasis. Even if you remove a little, it does not do anything good to the patient. Sometimes if you remove everything, it can do some good for a while. But if you're able to add chemotherapy after removing it, washing with chemotherapy, we now know around the world that there's evidence that it improves survival in stage 4 patients where it had spread already and we could not do anything before. This is just some of the rationale for why chemotherapy. I won't go into that. But these are just some of the studies. And if you can see, yung graph, yung blue line there, it's separate from the black line. It just goes to show that if you remove these tumors and wash them with chemotherapy inside the operating room, the survival is much better than if you cannot. The survival can be up to 22 months versus 13 months, or after 8 years, 45% of those were still alive if you had complete cytoreduction. Here in this other study, 39% were still alive after 3 years. Before, 6 months lang yan eh. Okay, and this is how we do it. We take out as much tumor as we can, and I won't go into the gory details. But after that, we wash with chemotherapy for 2 hours. It's a special machine like a dialysis. The chemotherapy is heated para it penetrates the areas better, and it goes in and out for 2 hours before we close the patient. And we've already had close to 20 patients in this hospital, and I'll tell you, many of them are still alive today. If we had not done this, I don't think they would have lasted 6 months. So that's our HIPEC program. That's our new addition to our colorectal cancer program. Let me now talk about this last topic. It's called ERAS, or Enhanced Recovery After Surgery. And even if we try to be good surgeons, technical skills, a lot of other things have to go into care for the patient so that they recover faster. What do the nurses do? What our anesthesiologists do? Their nutrition. how often do they get out of bed, things like that. And many of the practices I myself were trained on in the past ay lumang-luma na pala. For example, dati, hindi pinapakain yung pasyente the whole night bago operahan. Now we understand, hindi pala maganda yan sa pasyente kasi gutom ang pasyente, may effect rin sa blood sugar, may effect sa recovery. So now, under enhanced recovery, we can allow the patients to drink a special formula up to 2 hours before surgery. Dati rin, after surgery, hindi namin pinapakain kaagad. Hinihintay namin yung utot. That's the sign na we could feed them. And that takes around 3 to 5 days. Na maling-mali pala kasi patients need nutrients. Even the intestines need nutrients to function better. So, now, under our enhanced recovery, our patients are already drinking sa recovery room pa lang. And I'll talk a little about that. No? Kasi so, dami palang bago. No? So, ERAS is a multimodal perioperative care pathway to achieve early recovery. And we look at additional practices na wala palang ebidensya and replace them with evidence-based practice. It's comprehensive in scope and it covers all the journey of the patient. Bago pa ma-admit, pag na-admit, bago ma-operahan, during operation, after operation, pag nakauwi na. We look at all of that. It was started by this guy, Henrik Kellet. 15 years ago, he published in 1999 that he could send patients home in 2 days. No one believed him at the start, but they visited him and they found out it's true, so they started it. And the reason we show this slide, kasi from the ERAS Society ito they want to show you yung change, revolutionary change in medicine takes around 15 years bago umabot sa atin. And now it's reaching the Philippines. No? Anong gusto ng ERAS? Kung itong red line na yan ang nangyayari sa pasyente, pag na-operahan mo, may stress response, ang gusto ng ERAS, yung white dotted line, mas mababa ang response. So less surgical stress, less complications, shorter hospital stay, lower costs. I know there are some physicians representing the HMO industry here. They would want this. The evidence is strong. Shorter hospital stay with an ERAS program, reduce complications by 40% under an ERAS program. And I will tell you, I've been a colorectal surgeon for 20 years. Bilang ni Trixie. Colorectal surgery is among the general surgery specialties the one with the most complications kasi bituka. And yung bituka, ang daming mikrobyo. Kaya you always hear about yung mga nagsisepsis, yung nagkakaroon ng colostomy bag, yung kumakalat ito. It really is fraught with complications. And even now, I still get them. But that's why this program is important, to try to minimize those complications. And they now know that yung ERAS na maraming elements, the more you do the elements, the better the outcome. So for colorectal cancer here, readmission and length of stay bumababa pag 90% ang natutupad sa ERAS program. Pag complications, the more you follow the ERAS protocol, bumababa rin yung complications. This is foreign data, it's not ours. I'll show you ours later. They even now show, after 5 years from the surgery, yung mga mas maraming nagawa sa ERAS, mas maganda ang survival. So ERAS has been shown to work. They also show across the world, so it's spreading all over the world, na mas nakakatipid yung mga hospital, yung mga government institutions with an ERAS program because you reduce complications. The Wall Street Journal has taken notice. The other healthcare insurance companies have taken notice. Even the Americans have already studied it. In this study, they showed that even in the US, they will see cost savings. Okay, so it's coming. This is the ERAS Society, the International ERAS Society, and we wanted to be part of that. So the medical city, those of the medical city, we talked to them, we formed the ERAS Society for the Philippines, and the board of directors are all from here, because we contracted them to be the first ERAS center in the Philippines. So if you look, there are 100 units in 17 countries worldwide. Nandiyan ang Pilipinas, the first in Southeast Asia. Sumunod na lang ang Singapore. And we're in their website also in that red line. Sorry. This is our own data. If you look, since we looked at our own data from before we operate 2011, 2011 up to 2016. Yung compliance namin tumataas na because we're starting to follow. Pero 56% pa rin kasi yung previous years hindi maganda, siyempre. And then these are our complication rates. But I just wanted to show you that when we started the ERAS program na, you will see our compliance tumataas, our length of stay bumababa, our complications bumababa, and our number of patients tumataas. And if you just look at yung nangyayari 2016 lang kung saan full blast ng ERAS program namin, ang compliance rate namin 71% na, ang complication rates natin, our leak rate is only 1.9%, which is very low. And our length of stay, pag colon is around 3 days. Pag rectum, medyo mas matagal ng konti, mga 5 days. This is one of my last slides. And this is one of the first patients we had under our program. And he's not moving. He was moving. Okay. Anyway, he's one of our first patients, special adult yan. Not easy to talk to, but we cannot talk to him well kasi parang retarded na lubagin na. We had to do an open operation actually because he had very complicated colon disease. That's the first day. He's walking around already. One day after surgery, he was feeding. Dati hindi namin magawa yan eh. In fact, when we were starting, ayaw maglakad ng mga pasyente kasi akala nila yan ang dapat gawin, magpahinga sa kama. Ngayon, alam namin, sa recovery room pa lang, dapat umuupo na. The next day, 4 to 6 hours out of bed ng pasyente. Hindi dapat nakahiga sa kama at nanonood ng TV. Kung manonood sila ng TV, dapat nakaupo sa silya. Little things like that, inaayos namin. Dapat kumakain sa mesa, hindi sa kama. So these are the little things we have in our ERAS program. And we're really trying to cascade it as a responsibility of a center of excellence for ERAS. Our job is to spread it now all over the country. And we have training program in place. We've offered the program to Philippine General Hospital, to Southern Philippines Medical Center, to our other colorectal training programs in the government, so that we can implement it more widely in the country. Okay, so this is my last slide. Ang daming kailangan matutunan sa surgery for colorectal cancer. There's robotics. You know, I didn't learn that. I only learned that as a consultant. Yung high-tech namin, again, is recent. But tying that all together for quality surgery is, of course, yung enhanced recovery after surgery. And we have that all here for our Filipino patients in Medical City. So with that, I'd like to thank you for your attention.
Thank you very much, Dr. Rojas, for giving us a rundown of what's the latest high-tech, cutting-edge technology in the medical city. Rest assured the patients, when they come to the medical city, they get the best reviews. Patients to be equal and empowered partners. The medical city has been in the service of the Filipino for 50 years now. What is amazing for this institution is it continues to expand and grow as a healthcare network. The network is composed of the flagship hospital here in Ortigas, Pasig City. We have 4 provincial hospitals, and we have around 40 satellite clinics all over Metro Manila and outside Metro Manila.
And if that is not enough, the medical city has taken its brand of high-quality medical care into the global arena. It now owns and operates the Guam Regional Medical City. This is proof that high-quality medical care of the medical city knows no borders. I think this healthcare network makes the medical city unique, the only one in the Philippines. Standardization of high-quality care can be implemented throughout the network. So as a patient, wherever you go, as long as it is part of the network, you could get the same high-quality medical care. And I think this is another similarity we have with the Department of Health, where we have Department of Health composed of a network of the different city and municipal health offices nationwide. For our next talk, it will be on hitting the target in colorectal cancer treatment. Our speaker took up her medical school at the University of the Philippines. She did her medical residency at the Philippine General Hospital. She had her hematology and oncology fellowship at the University of Pittsburgh. She is the section chief of medical oncology and assistant director of the Cancer Center. Let us welcome Dr. Beatriz Yanko.
Magandang umaga po sa inyo lahat. Salamat po, Dr. Tayan, for raising this event, and Dr. Cairo, I know your person. Thank you for coming over. Tinatanong po ako ni Dr. Cairo kanina kung meron po tayong mga pasyente or kamag-anak ng pasyente na may colorectal cancer dito. Pwede po ba namin malaman? Ayan. Maraming salamat din po sa inyo. Sa totoo lang po, kahit po napakataas na po ng posisyon ng ating mga guests, mas mataas na rin po ang posisyon nyo. Kasi po, wala pong doktor kung walang pasyente. Imagine what we would be doing. Wala po kami matutulungan. And I hope po na nakakatulong din po kami kahit pa paano. Yun pong... Sige, tatayo na lang ako dito kasi iba yung nakikita ko doon. Okay. Pagka po nakita ninyo yung title ng talk ko, which is Hitting the Target colorectal cancer treatment. Siguro po ang iisipin po lalo ng mga pasyente na nabigyan na po ng mga bagong gamot na targeted treatment. Siguro isipin nyo na naman ito yung mga molecular targets na pinag-uusapan ko dito. Pero sa totoo lang po, mas malawak po yung perspective na ginawa ko o ginamit ko nung ginawa ko po itong talk na to. Kasi binagyan lang po ako ng 10 minutes. Pero hindi po katulad namin na siguro at least 20 years na working together as a team. Every cancer patient when newly diagnosed is the newest member of the team. And in fact, is being asked to be the head of the team. And so, it is important for that new team member to understand ano ba itong napasukan niya na hindi naman niya gustong pasukan, no? Parang nagising ka, bigla na lang you're part of this world called cancer. And certainly you need to know what's happening in order for you to get the best possible outcome. And really, truly, this is what participatory medicine is. And this is also what we are promoting here at the Medical City. So when I say begin with the end in mind, no, ano ba talaga ang target ng isang pasyente na napasok dito sa team na to na cancer treatment team? Unang-una po is first do no harm. No? This is, I think, more directed towards the doctors. No? And anyone who takes the oath to become a good doctor promises first to do no harm. And sometimes harm does not come in the form of doing something. It also comes in the form of not doing something. Meaning if we do not inform you of what your true options are, then maybe we are in a way doing harm. No? So we also have a duty to keep you updated and giving all our patients the best possible options in cancer treatment. And then there is when you have made sure that you're not doing any harm to your patient, then you start thinking of how can I do good? Ano bang pwede natin gawin para sa pasyente na may sakit? No? So, ano bang klaseng good ang pwedeng magawa natin para sa pasyente bagong hindi pa nga nagkakaroon ng cancer for the general public. And this is for more of us no, I'm not in DOH, but maybe those working in DOH, how can we actually prevent cancer? No? So what we need to do, our target is to prevent the preventable, to cure the curable, to extend the extendable, to accept the inevitable, and to improve the improvable. So my next few slides are going to help us find out how we can achieve these targets. Most of the morning, we actually have been talking about how we can prevent the preventable, because cancer indeed is preventable. And primary prevention involves the screening of healthy individuals but are at risk because of age or for any other reason, maybe family history. You can prevent these healthy individuals from developing cancer by, for example, giving vaccines to them. Kunyari, meron ho kayong high risk for developing liver cancer. What you want to do is have a vaccine against hepatitis because it is associated, hepatitis B and C is associated with liver cancer. You also can avoid developing cervical cancer by receiving the vaccine against human papillomavirus. So this is what's called primary prevention. Secondary prevention is achieved through screening. If you cannot prevent, kung nandyan na, hindi mo na mapipigilan ang paggawa ng cancer ng katawan mo, no? At least ma-discover mo early through screening methods, no? Bago kang may maramdaman, mag-screening method ka na, no? And this is what the screenable cancers are. There are 6 screenable cancers, and we'll see a short video on that later on. Next is, so if you cannot prevent the preventable, you cure the curable. What's the saddest thing would be seeing patients who could have been cured and yet were not. No? And this is a patient, he's actually pinsan ko siya. Meron din kami konting family history ng colon cancer. His name is Jerry Bulata. Of course, all of these pictures are with the permission of these patients. He was diagnosed with stage 3 colon cancer in 2013. And it's already 2017. He actually had only surgery, and because he was a very empowered patient, even if I was his medical oncologist, and I recommended that he undergo adjuvant treatment, he refused. And I accepted that because he's the patient and it's his body, and he's still alive now. He's not yet technically cured. He is now 4 years from his diagnosis, but we are still optimistic and hoping that he is cured, of course. No? So stages 1, 2, 3, and even 4 colon and rectal cancer are curable, especially if, number 1, the patient is fully aware of his diagnosis and stage. This is your life. You may as well get educated about it. The patient undergoes expertly delivered surgery, radiation, and chemotherapy. And that is what I guarantee we can offer you in this hospital. And a multidisciplinary team of experts should meet and strategize the plan of treatment together with the patient. And we have been doing our best to do this for several years now. And this same multidisciplinary team meets with the patient and the family and includes them in the final planning and decision making. Also, always remember, and this is for the doctors in the audience, always remember to refer patients to hospitals accredited by PhilHealth colorectal Z-package programs. This is a very good program of our government. They will offer you, in colorectal cancer, it's quite big, and I know Rami and myself, but especially Rami was key in developing these packages. And this will really go a long way in helping those who cannot afford treatment to go through the entire treatment process under the care of a multidisciplinary team. And yes, we are trying to initiate that in this hospital. Pretty soon, I'm optimistic we'll be able to start this. And even if it entails a little bit of extra work, assist the patient in acquiring needed documents for Philippine Charity Swift Office assistance. A lot of our patients, perhaps 50% of our patients here at the medical city, kasi yung impression ng iba, yung mga nandito, mga may kaya. Pero wala na hong may kaya sa cancer. Alam naman natin lahat, lalo na po sa mga pasyente na kahit po anong yaman ninyo, mas mahal pa rin ang gamot natin. So, karamihan po ng pasyente natin dito, nangangailangan pa rin ng tulong. And we are also here to help you with that. The goal is to cure the curable. And here on the left is another patient of mine, Rhonda Chica. He was diagnosed with stage 4 rectal cancer with liver metastasis in 2004. This one, technically, he is cured. No? When I use the word technical kasi po, sa mundo natin, pagka po ang pasyente, hindi pa po pinalikan ng sakit niya, 5 years after the diagnosis, he is considered cured. And 2004 is 13 years ago, so cured na po siya ngayon. Kahit po, stage 4 po ang cancer niya. Bakit? I think largely because talaga, he went through the proper treatment. He had a team, he went through chemotherapy, radiation, and surgery. Sixto de la Fuente was also diagnosed with stage 4 rectal cancer with liver metastasis in 2013, and he is very much alive today. So I included these pictures just to prove to you that even stage 4 colorectal cancer is still curable. So stage 4 colon cancer is curable 30% of the time if the primary site and the metastasis are treated early and properly. This is the patient has been makapagal, stage 4 colon cancer with peritoneal carcinomatosis, July 2013. She was the first patient of Dr. Rami Rojas and myself who underwent high-tech. Yun pong example ni Doc kanina na nakabukas po ang tiyan, na naglagay po ng chemotherapy sa loob ng tiyan, no? After reducing the tumor burden. She is still alive and doing well, and she is in the magazine that you will be given in a while. So, extendable people can live longer, happy and normal lives even if they have stage 4 colorectal cancer, provided the disease is under control. Targeted treatment has allowed such extension, so ito na yung targeted treatment na molecular, by working with chemotherapy in controlling the progression of the cancer. Advances in technology has allowed the identification of several new molecular targets. So ito naman yung isa mong ibig sabihin ng target in cancer treatment. Molecular targets that are now in fashion, so to speak. No? So these are the newest advances. So we also have to be able to hit the molecular targets if we want to extend the lives of our patients, usually stage 4 cancer patients. This is just a table of the common chemotherapy drugs in the first column, the class of drug, the target of the drug, and the average extension in weeks of life if you use this particular drug. So these are evidence-based. You look in the list below, the studies that have proven that there is benefit. But if you look at the last column, which is the average extension in weeks of life, based on these studies, you will see, for example, that FOLFOX alone extends the lives of patients by an average of 5.5 weeks. For those of us who are healthy, 5.5 weeks, we don't know how much that means, no, when you are actually under, your life is under threat, no, with devastating illness. So to some patients, this is worth it, and if they have the means, they are going to spend money in order for them to be able to buy the newest monoclonal antibodies or the newest targeted treatments. So ito po yung mga targeted treatment na available naman po sa atin dito na medyo pakita ko na lang po sa inyo kung magkano po sila. No? So ito po naman yung column na to, papakita po sa atin kung gaano kagastos. No? And this is maintenance. Wala hong hangganan to. Pagka kayo stage 4, many times ang buhay po ninyo depends on how long you can afford such medicines. Because if you stop treatment, then the disease becomes active again. So even if we do have available treatment that can extend the lives of our patients by a few weeks or a few months, and who are we to say whether this is worth it or not, we are going to also have to teach our patients to eventually accept the inevitable. So that's the target in this part of this slideshow, no? Accept the inevitable. This is a cartoon that I found very useful in my practice. It was given to me by one of my relatives. No? Charlie Brown here, looking out in the horizon, says, "Someday we will all die, Snoopy." No? So, which is true naman. Whether you have cancer or not, inevitably we're all going to die. But the complete picture says, at the same time we have to improve the improvable, because Snoopy says, true, but on all the other days, we will not. We're not dead yet. Even if you're stage 4 cancer, newly diagnosed, ang unang iniisip ng pasyente, mamamatay na siya. Pero, alam mo naman yan, nung pinanganak ka, mamamatay ka, no? What you have to be more acutely aware of is the fact that you're not dead yet. And when I put this in my clinic, I can tell you the number of patients who actually took pictures of this poster that I put up. No? It helps to be reminded that there is always hope. No? So, and while hindi pa po tayo kinukuha ng Diyos, wala pa po sa tadhana natin, nakunin na tayo, we have to be able to improve the quality of lives, especially of patients, no, who are under threat of disease. So we have to maximize the quality of life and give importance also to the quality of death. No? So these are very important things that we have to consider. And again, I was having conversation here with Dr. Caio earlier, and the sad fact is, when they look at all the countries, many countries with palliative care specialists, and when they looked at the quality of death, the Philippines actually ranked third to the bottom. And only 2 other countries had worse qualities of death for their patients compared to the Philippines. So we have a lot of work to do for our patients, because if inevitably we're all going to die, we may as well do our best to make the quality of death as easy or as with best quality as possible. And how this is defined is very interesting, but that's not the topic of our talk. So this is my last slide, no? And I think it's important for the doctors to realize that it's not their life that we're talking about. And it's very important to always bring home everything, target on the quality of life and the quality of death and on the decision-making process of the patient in front of you. It's easy for us doctors to want to do this or that because we can do it, because we are very sure that we can save their life. And, you know, it's not a bad thing or a bad attitude to have. But remember, the patient is always going to have to consider not just what the evidence is saying, but also what resources do they have. And where do they want to distribute these resources? Is it necessarily just for themselves, over 150,000 a month for the rest of their lives? Or are there more important things that this money can go to that is important to them and their family? So while we can offer you the best, the final decision as to what options you will choose is really just yours to make, and we will certainly respect that. But if ever you want a multidisciplinary approach and the options available to you, we have them all here at the Medical City. So thank you very much.
Thank you very much, Dr. Bianco, for that very heartwarming lecture. I